today we're going to be talking about male gonadal disorders or male reproductive disorders. We'll talk about how to make a diagnosis, different causes, symptoms, testosterone treatment in older men, and risks versus benefits of testosterone treatment. So testosterone is a pretty controversial area within our field, and it definitely gets a lot of popular press. Dr. Google tells a lot of men, they have to have their testosterone levels checked. There's data on their safety data. There's concerns about links to cardiovascular disease. So it's definitely important to kind of know the ins and outs of testosterone therapy in men. This is looking at a graph in terms of trends for increased testosterone testing in the last decade, and for us versus the UK. So you can see as time has gone on, just the amount of testosterone testing that we are doing has skyrocketed, and the amount of testosterone prescriptions that have been prescribed has also skyrocketed. I mean, if you actually further look at who is prescribing testosterone, why are so many testosterone prescriptions being written? It's actually mostly by urologists and primary care doctors. The rates in terms of endocrinologists prescribing testosterone has actually stayed about stable. But as we can see, the number of people using testosterone has really skyrocketed in the last many years. It's a money-making market. There's a lot of different formulations out there. There's IM testosterone, there's androderm, which is, I don't know if you guys can see my mouse here, but there's androderm, which is a patch. There's Axiron, which is looks like a deodorant type of stick. There's Natesto, which is a nasal spray. There's testosterone pellets, which are implanted under the skin. And then there's a buccal tablet that no one uses. So we'll start with a case here. It's a 75-year-old man. He is concerned about fatigue, erectile dysfunction, breast enlargement, and gaining belly fat. He went through normal puberty, but he does have a history of infertility. Past history, he has a history of coronary artery disease, status post-MI, and status post-PCI. He also has a history of blood clots. He has a history of hypertension, high cholesterol, prediabetes. He's like your typical internal medicine and endocrine patient here at Georgetown. In terms of his medications, he's anticoagulated. He's on aspirin, Plavix, and Coumadin. He's on a statin. He's on some blood pressure meds. He's on quite a cocktail. On physical exam, he's got a pretty normal blood pressure. He's heavy, but he's overweight. He's got a BMI of 27, central fat distribution. He's got kyphosis. He has sparse axillary facial hair, and he has bilateral gynecomastia. His testes are 6 milliliters bilaterally and very soft and kind of squishy. And I can tell you that 6 milliliters is tiny. That's on par with a prepubertal testicular size. And also the soft consistency. Testes should be larger. They should be anywhere from 15 to 20 milliliters in size. And when you do a testicular exam, it's firm. It firms, kind of bounces back. One of the signs of a hypogonadal man is a smushy sort of texture to the testes. In terms of his initial lab data, we know that he's heterozygous for factor V Leiden, probably that DVT history, and his free testosterone is extremely low. Would you prescribe testosterone at this point? So let's kind of get into some of the data here. Clinical presentation of hypogonadism. In terms of prepubertal presentation, we see scant or absent pubic or axillary and facial hair, small testes, small prostate, small phallus, disproportionately long arms and legs are getting at Klinefelters there, decreased musculature, persistent high-pitched voice, and then gynecomastia. In terms of post-pubertal presentation of hypogonadism, we look at a late decline of secondary sexual characteristics, pubic, axillary, facial hair. They may have small testes. They may have had normal sized testes and then have noticed a decrease in size. They will have a normal sized phallus, normal appendicular skeleton, might have decreased musculature. They'd have a normal pitched voice. They can have gynecomastia, osteoporosis, and depression. When we think about hypogonadism, we separate it into primary versus secondary causes. Primary would be gonadal failure. Like this is a primary testicular problem that can be either congenital or acquired. And then in terms of secondary causes, we think more about the level of the pituitary, and that would be like a low FSH, LH kind of form where like the pituitary is not sending the appropriate signals to the testes to produce testosterone. And that can be genetic, that can be structural or functional, which we'll get into. How this pathway, we in endocrinology, we love feedback loops. It's like our favorite thing ever. And so we've got the hypothalamus, secretes GnRH. GnRH works on the anterior pituitary gland to secrete FSH and LH. FSH mostly exerts its effect on the Sertoli cells, which are responsible for spermatogenesis. And then the Leydig cells, LH works on the Leydig cells to produce testosterone, the end result being primary and secondary sexual characteristics. So when we think about, these are secondary causes, gonadotropin deficiency, deficiency of FSH and LH. Things that we think about are pituitary tumors, some type of traumatic head injury, radiation, CNS radiation, and infiltrative disorders such as hemochromatosis, sarcoid infection, or metastases. Functional causes being like people who are really sick, people with renal failure, diabetes, different types of cancer, COPD, people who are malnourished, excessive exercise, kind of like the female athlete triad, but you can actually see it in men also. Anabolic steroid use, opiates. Actually, long-term use of pain medication can present a secondary hypogonadism, as well as autoimmune causes. And then if we get into primary hypogonadism, these are primary testicular issues, anorchia, vanishing testes syndrome, bilateral cryptorchid, I don't actually know how to say that, but that word, Klinefelter's, and then also like a 45XO carrier type. Most common likely being Klinefelter's that we see. Acquired orchitis. Actually, that's quite common in mumps. So in our patients who are older, like not our 20, 30-year-olds, but like patients who are like 60s, 70s and older, like I always ask them if they had the mumps, because that can be an acquired form of hypogonadism. Testicular torsion, there's a reason why it's a urologic emergency. It can really cause damage and they can have acquired hypogonadism as well as infertility. Blunt trauma to the testes, vascular injury, testicular radiation, chronic illness, cirrhosis, and then if you have an orchiectomy and you don't have testes, then you have acquired hypogonadism. Diagnostic workup of androgen deficiency. So usually this takes place in your general physical exam. The testosterone level, it should be checked as an early morning sample. We get a lot of consults for testosterone levels that are drawn at like 4 and 5 o'clock p.m. Like that's not what we want to see. The normal range for a testosterone level in the lab is an 8 a.m. level, and it is fasting. The reason for that, well, so interestingly, testosterone levels peak the less time you are from sleep. So 8 a.m. is generally a good time to get to the lab, but the more time you are from sleep, like if someone wakes up at 8 a.m., testosterone levels peak at that time and then continue to trend down throughout the day. If someone wakes up at 6 a.m., generally their testosterone peaks upon waking and then trends down throughout the day. Looking at a testosterone level less than 200, androgen deficiency is very highly likely. Over 400, they're fine. Between 200 and 400 is kind of this gray zone, and at that time we recommend repeating an early morning testosterone level and then looking at more specific assays to include a free testosterone. I check it by mass spec, and we'll talk about why. So then let's say you do have a confirmed low T. Then we need to get into like, is this primary? Is this a testicular problem or is this a pituitary problem? We measure FSH and LH. If it's a primary testicular problem, the FSH and LH are going to be high because the pituitary is saying the testes aren't working and the pituitary is churning out more signal trying to get the testes to respond. So that's here on the right. Hypergonadotrophic hypogonadism, and at that point you're going to be obtaining a carrier type and looking for Klinefelter's. In the opposite here, low or inappropriately normal FSH and LH, that's the secondary hypogonadism. We're looking at systemic illness. We want to see, could this be a pituitary tumor? Could this be hyperprolactinemia? The ferritin is getting at iron overload as a cause. Evaluate for other secondary pituitary deficiencies, like look at the pituitary, see if there's anything going on there. This is the Endocrine Society guidelines for diagnosing androgen deficiency in men. So we diagnose only in men with consistent signs and symptoms of unequivocally low testosterone levels. And then we measure the AM total testosterone using a reliable assay. And then if you do get a low testosterone, we do want to confirm the diagnosis by a repeat measurement. So we always want to see at least 2 levels that are unequivocally low. If total testosterone is low normal, so this is what you're going to see in like your obese type 2 diabetics, you're going to see levels of like 250, 280, like low 300s. That's when we start to think about altered SHBG, sex hormone binding globulin levels. And that's when we'll look at the free and bioavailable testosterone. And we'll get into the SHBG issue. Do not make the diagnosis during an acute illness. So like when someone is very sick in the hospital, is not the time to be checking testosterone levels. This is kind of getting at the circadian variation in testosterone levels, and this is why we really want you to check the levels early in the morning, because we've got a peak early in the morning, and then it kind of fluctuates, trend down throughout the day, and then starts to rise again between 4 and 8 in the morning. So this is getting at why we care about the SHBG and the free testosterone. So essentially, when you're looking at testosterone, testosterone is measured as, like total testosterone in the lab is measured as testosterone bound to protein. So albumin bound and sex hormone binding globulin bound. So there are different things that can affect the binding globulins, and we'll get into that. Binding protein levels can be affected by aging, obesity, hyperthyroidism, liver disease, and genetics. Binding protein concentrations may be independently associated with metabolic outcomes, and there are also just genetic differences in binding proteins. So you might have 2 people side by side, person A, person B, they actually have the exact same amount of testosterone, but like person A might have lower binding globulin, so their testosterone is going to look lower in the lab. So that is to say that if it's nice to get a free testosterone because we remove the confounding factor of the binding globulins. We remove the confounding factors of the albumin and the SHBG levels. So this is a big one here. What makes the protein level, what makes the SHBG, for example, look lower? Obesity. So that's a big one, because the people, like I often see in clinic, my overweight diabetics are complaining about, erectile dysfunction, concern for low T, and of course their total testosterone is going to be in the 200s, or it's going to come either like the lowest end of normal or like right below the lowest end of normal, and then inevitably I check their SHBG, I check their free testosterone, and these are patients who have low SHBG related to obesity, so their total testosterone is low, but if you strip the binding globulins away and measure their free testosterone, it's actually normal, and they don't need testosterone. Other things that can lower SHBG, hypothyroidism, steroid use, nephrotic syndrome, things that increase SHBG, aging, hyperthyroidism, androgen deficiency, estrogens, anticonvulsants. People with cirrhosis have very high SHBG levels, and HIV. So going back to the case that we were talking about before, so our gentleman, he has, with the history of coronary artery disease and DVT, he has very low total testosterone. I mean, 77 and 90 on repeated levels, repeated draws. That's not borderline, that's super low. His estrogen level is low. His SHBG is normal. He's got an LH and an FSH that are very elevated. So this guy's got primary hypogonadism. So what additional tests would be helpful? So usually when I'm with you guys in person, someone would answer me, but I'll just tell you, we want to get a karyotype. This guy is a 46XY. So we're looking at probably, this guy doesn't have Klinefelters. This is probably something that was acquired. So I'm thinking, do I want to start him on testosterone? What other information would I want? So I do want to get a PSA, which is 2.1. We'll get into this later, but testosterone therapy, we do need to consider risk for prostate cancer. Testosterone therapy will unmask prostate cancer sooner. It does not cause prostate cancer, but if you do have like smoldering prostate cancer, it will unmask it sooner. We also look at the hemoglobin hematocrit. He's got a crit of 33%. And then this is a guy with such low levels of testosterone. I want to look at his bone density because we know that low testosterone is associated with lower bone mineral density. So this guy has got compression fractures at T10 through T12. And he's got a T-score in the osteopenic range of -2.2 at the femoral neck. So this guy's really been affected by the low T. So should this gentleman be treated with testosterone? This is where I would ask for a show of hands. So my answer on this, so at least when I gave this lecture last year, actually most people in the audience felt actually that they would not prescribe this man testosterone. And that was because of like his significant history of coronary artery disease, his significant history of DVT. On purpose, this guy's got like every risk factor in the book. My answer on this gentleman would actually be the opposite. I would treat him with testosterone. There is data out of the androgen deprivation literature that actually there is an increased risk of coronary artery disease with testosterone levels that are this low. This guy is anticoagulated already, which would also kind of mitigate our concern for risk of DVT and thrombosis in him, and we can see that it's having a major effect on his bone density. So I actually would treat this guy, and my plan would be to give him testosterone with an aim to just get him into like that 300 to 400 range, kind of the lower end of normal, and let him be. Here's another case. This is a 71-year-old retired school bus driver. He has type 2 diabetes. He has hyperlipidemia, here for low T. He has gradual erectile dysfunction. He hasn't tried something like Viagra or Cialis. He's having fewer morning erections than he did in the past. And his libido is, he complains his libido is not like it was when he was 20. His medications, he's on a statin, he's on metformin, he's on aspirin, and he's on Actos or pioglitazone. He's quite overweight. He's got a little bit of high blood pressure. BMI is of 32. Physical exams really unremarkable. And so he's got his AM total testosterone, like I mentioned to you, would be the case in many of your diabetics, 269, 291, just below the lower limit of normal. And these are total testosterone levels. It's got an A1C of 7.3. So what do we do with these total testosterone levels between 200 and 350? So just looking at these kind of people with borderline levels, if you look at the number, so these are the people that aren't as fit, is what this is showing us. Most of these people are doing no exercise per week. Less people who are actually exercising per week have these borderline levels. And then if you look at these borderline levels, they increase significantly with weight. So these are we see these especially in obese patients. And then just to show you here, there is a large overlap with depression in general. And the symptoms of low T are also the symptoms of depression. This is a bar graph looking at the percent hypogonadism by decade of age. And this is just to show, if we define hypogonadism by testosterone levels less than 300, this is just to show that testosterone levels decline with age. If you're in your 70s, 80s, 60s, even 50s, you don't have the levels of testosterone as someone in their 20s and 30s. And that's not a bad thing. That's not abnormal. This is just another way to look at it. Younger people have higher testosterone levels and they decline with age. This is just a sort of a proposed level of, this is looking at proposing changing the normal range of testosterone to actually correspond with age, changing the new lower limit of normal. And then this is just to show you that testosterone levels decline with age, and that this is not necessarily so abnormal to have these, what we would call borderline levels as you get older. So this is the consensus statement on we're talking about late onset, like hypogonadism in adults, not that they've had since childhood. This is just looking at testosterone level, total testosterone level less than 230 usually benefits from therapy, greater than 350, no treatment, and then in between, repeat level, look at free testosterone. So looking at erectile dysfunction, the reason I show this table is to say that erectile dysfunction is not always related to hypogonadism. In fact, most people with erectile dysfunction don't actually have low testosterone levels. And this is just to show that erectile dysfunction can be caused by a lot of things. Aging is a big one, depression, anxiety, vascular diseases, atherosclerosis, antihypertensive, diabetes, renal failure, hyperlipidemia, metabolic disorder. Like there's a ton of things that can cause erectile dysfunction that aren't necessarily correlated with the actual testosterone level. Age is the #1 risk factor for erectile dysfunction. This is looking at, this particular study looked at rates of erectile dysfunction, and as you can see, it significantly increases with age. Also, this is a graph looking at testosterone and body mass index. So in addition to testosterone declining with age, testosterone declines, there's an inverse relation with testosterone and BMI. So we can see here that the red is the red BMI. These are the heaviest patients here. And so you can see that both free testosterone and total testosterone levels are significantly lower with the heavier patients, as well as the SHBG levels increase with age, LH levels increase with age. But take away from this that BMI up, testosterone down is what I want you to take away from that. Health and lifestyle issues that adversely affect testicular function. We've touched on this: obesity, sleep deprivation, systemic illness, diabetes, renal failure, cardiorespiratory failure, inflammatory bowel disease, medications like opioids, steroids, and alcoholism. So this is looking at, this is the Institute of Medicine guidelines for testosterone replacement in elderly men. So the takeaway point here is that we need to be more stringent. We need to be a little bit more strict about who we're prescribing testosterone for, because testosterone is not without risk. It should not be in the borderline cases. It should be in like really slam dunk hypogonadism. We want to maintain levels only in the mid-normal range. You'll see on like the lab, the normal range goes up to 1200. I've never seen anyone with a testosterone level of 1200 without testosterone therapy. The Endocrine Society guidelines say to aim for a range between 400 and 700 in someone on testosterone replacement. And then we should also just watch them, given that we should watch them carefully, given that we know that testosterone replacement is not without risk. Other things, so we know that late onset hypogonadism increases with advanced male age. It's highly associated with health and lifestyle changes, obesity, type 2 diabetes, sleep apnea, all contribute. Healthy men of advancing age appear not to demonstrate age-related decline in serum testosterone. We've talked about androgen replacement should be approached conservatively. And then also try to, like, if they do have a reversible cause like obesity, diabetes, sleep disturbance, like treat the underlying cause. You try to get the men to lose weight, control their diabetes, treat their sleep apnea, because you might see that actually helps without having to put them on testosterone therapy. This just shows that losing weight helps. Percent body weight loss, we can see there's a direct relation. The more weight they lose, the more their testosterone levels increase. So sometimes the way to treat low T is not with testosterone replacement, it's to tell the patient to lose weight. So to treat or not to treat, benefits of testosterone therapy. So you might have heard of the T trials, the testosterone trials. These were 7 coordinated trials looking at sexual function, physical function, and vitality. And the goal was to determine the efficacy of testosterone in improving sexual function, physical function, and vitality in older men with unequivocally low testosterone levels, low libido, mobility limitation, and low vitality. It was double-blind, placebo-controlled. So there's a lot of studies, and it's kind of long, so I'm just going to summarize them for you. So yeah, we'll just summarize them because they're otherwise long and boring. So testosterone effects on sexual dysfunction, no beneficial effects in men who had normal testosterone levels and no symptoms. Testosterone replacement therapy does improve sex drive. It improves overall sexual activity and satisfaction with erectile function in hypogonadal men, and unequivocally low testosterone levels and decreased libido. It does not improve ejaculatory function or response to an optimized dose of a PDE5 inhibitor like Viagra. And why I mention that is because a lot of patients will say, you know, they come in with erectile dysfunction, and so the testosterone helps the drive, especially, and like the satisfaction with their sex drives and with their performance. But if someone has ejaculatory dysfunction, testosterone is not necessarily going to help them. And so I always make that clear to my patients that this is not necessarily the magic bullet. Testosterone supplementation does improve muscle mass and maximal voluntary strength and power. It does not improve the contractile properties in skeletal muscle. The gains in muscle mass and strength are dose related. That's why you see patients who take super physiologic doses of testosterone, they form a lot of muscle. Improvements in stair climbing power and gait speed with replacement doses are small, and clinical meaningfulness remains unclear. And it is possible that testosterone replacement may improve physical performance when administered with task-specific training. Here's a summary in terms of bone mineral density. It does improve vertebral and possibly femoral BMD and bone strength, which is why I want to treat that guy with very low T and the compression fractures. Cognition, no significant effect on any domain of cognition, no overall effect on quality of life, no meaningful improvement in fatigue in the testosterone trials, and no clear improvement in clinical depression. And so these are all like symptoms people will come in telling you, you know, it's got to be my testosterone, doc. I need my testosterone. And this is data that we need to be able to tell people that like this is not, it doesn't necessarily fix all of these things that they're necessarily complaining about. So another summary, which we've already been over. Sorry if this is repetitive. Testosterone replacement improves libido, erectile function, and overall sexual activity, but the improvements are modest. Testosterone increases muscle mass and strength, but the improvements in gait speed were small. Testosterone's efficacy is in improving hard clinical outcomes like fractures, falls, disability, depression, progression to diabetes, and dementia remain unknown. And the long-term risks of testosterone replacement are unknown. So in terms of, so let's talk about like the negatives of testosterone therapy. So we know on the left, adverse events for which there is an evidence of association. Acne, people can get acne and oily skin. Erythrocytosis, it can raise the hematocrit. We do have to stop it or look for other causes when people reach a hematocrit of about 51%. Testicular atrophy and infertility. You know, the fastest way to make a man of reproductive age infertile is to give him testosterone. So there are implications in terms of their future fertility. Increasing the risk of detection of prostate events, i.e. it unmasks prostate cancer when it's faster, when it's already there. Increasing the growth of metastatic prostate cancer. And just some formulations have some adverse reactions, like people get rashes with the androderm patches, for example. Adverse events for which there is a weak or inconclusive evidence of association, gynecomastia, prostate cancer, OSA, cardiovascular events. Low testosterone is associated with an increased risk of cardiovascular disease. So this is somewhat of a controversial statement. There are some studies linking low T with increased CVD and mortality. We also know out of the androgen deprivation literature that very low T increases the risk of CAD as well. But then there's also potential benefits of testosterone on cardiovascular disease risk. The coronary vasodilator, it can reduce cholesterol levels, decrease inflammatory cytokines, reduce plaque formation. So there's mixed evidence on the relationship of low T and coronary artery disease. So this is just kind of looking at cross-sectional studies, low testosterone in terms of studies that showed an increased risk of coronary artery disease. It's about half, and only 1 of 4 prospective cohort. Looking at low testosterone, no coronary artery disease effect, the other half, and 3 out of 4 prospective cohort studies. So there's an inconsistent relationship between serum testosterone levels and cardiovascular events. This is just another slide showing that the results are mixed. Why might they be mixed? The study populations are mixed. I mean, people with low testosterone, they generally tend to be like a sicker population in the first place, and a sicker population you might expect may have worse cardiovascular outcomes. Also, the testosterone levels in the labs aren't necessarily standardized across different labs. Unclear why certain people are being treated, what certain treatment regimens are. There's no like standardization. And so we have to keep that in mind when we think about the outcomes of these studies and their generalizability to a wider patient population. Reconciling the paradox. So low endogenous testosterone and increased cardiovascular disease risk, it may be a marker of ill health in general and reflect an adaptive response to chronic disease, or it may contribute to atherosclerosis by predisposing to obesity, metabolic syndrome, and type 2 diabetes. When we look at prescribing testosterone and increased cardiovascular disease risk, the concern there is an acute increase in testosterone and estrogen levels may promote a prothrombotic state by increasing, I think that was supposed to say platelet aggregation. So pretty much what do we do with this information? Because I think the overall answer you might be getting is that like there's so much that's unknown and we really don't know is the answer, is that now there's like new labeling guidelines on all testosterone products saying that it's only approved for men with very low T levels and that we need more further studies to really ascertain whether this is safe or not. So then how do you know what to do? So we look at our known knowns. In men with classic hypogonadism, unequivocally low testosterone, the risk-benefit ratio favors testosterone treatment. We look at, so we know that this is for young people, primary hypogonadism, they'll go through puberty, it improves sexual function, it enhances mood and well-being, it increases muscle mass and strength, it increases bone mineral density. Negative effects that we know of, potentially acne and an increase in hematocrit. Known unknowns. In older men with low T of unclear etiology, the long-term benefits are a little bit uncertain, and cardiovascular safety is a concern. So we look at kind of the positive, which we just talked about, the negative, which we've also talked about, and then kind of the inconsistent, what we don't know. I'll just kind of let you guys read that because I can read this too, or you can read it. So what does this tell us? We just need to carefully select our patients, and we need to watch the levels and actually monitor patients on this. We don't give them testosterone and like never see them again. We do watch them and monitor for any comorbidities that may occur. We discontinue treatment if side effects develop, if their symptoms do not improve, or their inciting factor resolves, i.e. like they lose a lot of weight, for example. Take-home points. We recognize that the non-specific nature of most symptoms of male hypogonadism. To be honest with you, the vast majority of patients that come into my office concerned about low testosterone with very non-specific concerns. My energy is low, I'm not getting muscle, I'm really tired. They don't end up having low testosterone. Recognize the limitations of the reference range. Recognize the limitations of the guidelines given the low quality of most of the studies. Clarify what low libido represents to the patient, what else is going on, recognize the association between obesity and low SHBG and total testosterone levels, educate men with borderline testosterone levels about mean levels and variability. And what that's getting at is, your middle-aged male that comes in with a testosterone level of 300, and they say, well, my level's not 1200, it should be higher. There is no like quote unquote normal level of testosterone. You know, everyone experiences different levels of either dysfunction or, you know, there's nothing that says a testosterone level of 800 is better than a testosterone level of 400. You know, it's not, it doesn't go kind of in that linear aspect of way of things. And also that testosterone levels do normally decline with age, and that's not a developmentally bad thing. Take-home points, we talked about approaching testosterone replacement in older men, and we talked about the risks versus the benefits of testosterone replacement. And in the end, we know that the cardiovascular risk is a concern, but it's not clear-cut, and that more studies are needed. So in the end, you really should select your patients carefully as to who really does need testosterone and who does not.